Thank you very much. I'd like to thank the organizing committee for inviting me to present our data on this topic. So I'll be talking about whether we can consider visual snow a thalamocortical dysrhythmia. I don't have any financial disclosures, but I'd like to acknowledge the support that we've had in taking out this work by the NANAS pilot grant in 2018. Most of you will be familiar with visual snow as a disease that we do see in our neuroophthalmic patients. It's the presence of small dynamic flickering dots throughout the entire visual field that is persistent, and it often occurs in a whole constellation of visual and non-visual associated symptoms. So these patients often experience a whole range of palinopsia, such as trailing or after images. They're aware of entoptic phenomena, particularly blue field phenomena, or things like Scherer's phenomenon, looking at little white cells going through the retinal vasculature. They also experience photophobia and nyctalopia. Some of the non-visual symptoms that patients often complain about is comorbid migraine, which is quite frequent, as well as tinnitus and tremor. And a recent publication by Pauletta earlier this year has nicely characterized this spectrum. So it's really a spectrum of disease of visual snow by itself all the way to visual snow syndrome. And these are the diagnostic criteria that you can see. Despite a lot of research going into visual snow over the last couple of decades, we still don't know the exact pathophysiology of this condition, and there's a whole range of theories around what we think may be going on. There is general consensus that the retinotopic distribution of the disease, as well as the phenomenon occurring in the whole visual field, suggests it's likely a disorder posterior to the lateral geniculate nucleus, or a disorder of the posterior visual pathway, although some authors still debate that as well. Several theories exist as to the cause of this disease, and they generally center around perception of subthreshold stimuli. And so we've got evidence from research around cortical hyperexcitability or hyperresponsiveness. Some of the data comes from the original study by Schenken et al. In 2014, where they found hypermetabolism, for example, in visual areas on PET scan. And some of the other publications, for example, by the group of Owen White from Melbourne, focus more on behavioral measures of cortical hyperexcitability. The other line of thought comes from electrophysiological studies. So we've got evidence that patients with visual snow lack habituation or have reduced habituation. There's been a paper by Fantini. This has been somewhat criticized because I think it wasn't very clear to what extent the pathophysiology is related to the comorbid migraine, where we know reduced habituation occurs, and to what extent is actually the result of visual snow. We've previously hypothesized that visual snow is the result of a thalamocortical dysrhythmia. We know that thalamic neurons generally alter the threshold for sensory detection through a mechanism of inhibition. Similar to some of the comorbid diseases of migraine and tinnitus, we know from research in those areas that, for example, in the case of migraine, the thalamic neurons can reduce the sensory threshold, and that's the reason why patients with migraines are much more sensitive to visual stimuli, so photophobic, and, for example, also auditory stimuli, such as phonophobia. We also know from recent study in tinnitus that a mechanism is thought to be similar, and so patients are much more aware of subthreshold stimuli, and that's a mechanism of the pathophysiology in the tinnitus. And so we've previously suggested this in a case series and think that visual snow may represent a visual correlate of tinnitus, so a same pathophysiology. So we set out in this study to prove this hypothesis. We recruited 20 visual snow participants that were diagnosed with classic visual snow according to the diagnostic criteria by a neuroophthalmologist. We then also recruited 16 healthy age and gender match controls. Now, because of the controversy around which features are explained by the visual snow themselves and which features are really part of the comorbid migraine, we've decided to recruit a second control group, which is a migraine-only control group. And at this stage, we've got 8 patients recruited into the second control group. The patients underwent magnetic encephalography testing. Now, I'm not sure how familiar everyone is with this particular technology because it's not that commonly used. It's got several advantages over some of the other methodologies that we use to evaluate this, such as fMRI, PET, or EEGs. So if we look at functional MRI, for example, it really measures cortical blood flow, and it relies on the hypothesis or on the fact that we link cerebral blood flow to neuronal activity. So therefore, it's really an indirect marker of neuronal activity. Similarly, with PET scanning relies on metabolic activity, and then we therefore infer an increased neuronal activity from that. In contrast, MEG testing actually measures absolute neuronal activity, and that gives us a much better temporal resolution of the data. If we compare MEG to, for example, EEG, which is the other related technology, EEG measures the electrical currents on the cortical surface, but these are much more prone to distortion from, for example, bony changes or skin changes, etc. So the magnetic fields that we measure in MEG tend to be a lot more stable, and that gives us better spatial resolution and therefore better localization, which is what we want in trying to ascertain where the pathology lies in this disorder. So looking at our testing protocols, so patients generally entered this sort of magnetically shielded room. They were provided with a cap, so it's a non-invasive technology. The reference electrodes were mapped to an MRI scan for anatomical localization, and then the patients were lying supine within this space looking at a screen. And we then periodically engaged them with a black and white grating task for about 1.5 seconds to visually stimulate. To ensure that they maintain attention, we integrated this alien zapping game. So at the end of each visual grating, a green alien or a flower or another unrelated image was presented to the patient, and they were instructed to press a button to make sure they maintain visual attention throughout the 25-minute testing protocol. And we specifically looked at the primary visual area in this study and looked at 3 parameters. The first one is our high-frequency gamma band. So the gamma band generally refers to a focal cortical activity, in this particular case to the focal sensory processing within the primary visual cortex. We then also looked at the low-frequency alpha oscillations. So alpha oscillations are really the dominant oscillations in the human brain, in fact. They're generally related to the role of information processing and often have inhibitory control throughout which they modulate individual cortical networks. And lastly, we looked at the alpha-gamma phase amplitude coupling, and that information really tells us about the control or the alpha-thalamic control of the specific cortical area in this setting. So looking at the result here, you can see the heat maps. So these are the measurements for our gamma power, so our local cortical activity within the visual cortex. And you can see this characteristic stimulus increase in gamma power in relation to the visual stimulation. And that fits with what we would expect. So as the patient sees the visual grating, we've got activation, increased synchronization within our primary visual cortex as a response to the stimulus. And if we compare our 3 different groups, there was no difference in the peak frequency, which is what we would expect. Of note there, you can see that the migraine group actually had a really large amplitude that was not statistically significant, but it's certainly something that has been described in the literature previously. And if we look at the gamma power change between the resting state and the visual stimulation, although there was a similar spread, we actually found a greater gamma power change for patients with visual snow between the resting state and stimulation. If we look at the alpha power band between the 3 different groups here, you can see again in relation to the visual stimulation, there was a decrease in alpha power observed, so in the blue, so in the negative spectrum there. Again, that fits with what we would expect. So alpha currents exert control through dysynchronization, and that's the way in which they inhibit local cortical networks. So a negative power response is what we would expect in that context. Again, if we look at the frequency, there was no difference in the peak frequency band, which just shows us we've got good alpha data. And if we've looked at the difference in power, there's no difference in the general alpha oscillations in the different patient groups. And then most interestingly, we are looking at the coupling. So again, the coupling tells us about how this particular alpha band has controlled the local visual cortex. And these are heat maps here, and you will see that a redder heat suggests synchronization or coupling as compared to a sort of whitish or more bluish area which suggests desynchronization. And it's very obvious that in control group and also in the migraine group, there is very clear areas of coupling and synchronization. And that's very much in contrast to our visual snow group, where we do not observe any area of phase amplitude coupling whatsoever within that range. So in summary, what we see that the gamma power bands that relate to our local cortical activity in the visual cortex actually show in our study significant greater gamma power in relation to a visual stimulus in those with visual snow. And really what we can infer from that is that can be used as a functional correlate for what we know is cortical hyperexcitability. When we look at the alpha-gamma frequency phase amplitude coupling, which we use as a marker of the thalamocortical control, especially the inhibition, what we found is that there's no coupling whatsoever in the primary visual cortex in those patients that have visual snow compared to migraine or control, and that was significant. And again, this lack of phasic coupling suggests that this inhibition for visual processing is lost in our snow patients. So in conclusion, this data really nicely supports, number one, the theories that we already know about. So it supports the notion that visual snow patients have local cortical excitability, but more importantly, it also confirms our suspicion that we can think of visual snow as a thalamocortical dysrhythmia of the visual system. Again, what's the chicken or what's the egg? At this stage, we do not know. Is this a bottom-up mechanism? Is there an atypical organization of the columns within the occipital cortex or at a cellular level, which causes the hyperexcitability and then the subsequent changes? Or is this a sort of top-down problem where it's the thalamic inhibitory neurons that have the pathology and the resultant disinhibition is what actually causes the focal hyperexcitability? And there certainly needs to be more work done in that regard. From our perspective, where to from here? So this is obviously a work in progress. So we're still recruiting patients into the study, especially our migraine control patients, to make that group and that data a little bit more robust. And also we're looking at other areas. So the original paper, for example, by Schenken identified the lingual gyrus, so V2 visual areas, an area of interest. We'll also be looking at some of the visual association areas to try and tease out a little bit more where the primary pathology might be. So even though this data is not necessarily going to immediately translate to any change in patient management for these visual snow patients, certainly has provided us with another neurophysiological substrate for the actual pathophysiology. It may allow us to quantify things, and it might even help us to measure any treatment response for this in the future. And I'd like to acknowledge all the collaborators on this work, and also especially my supervisor, Associate Professor Claire Fraser. Thank you very much.
So a couple of questions from the audience. Did you look at how long the patients had visual snow for before the study, and if that affected the results at all?
We haven't analyzed that data, but we've certainly collected the data. So there's a range. So the age range in this patient cohort was somewhere from 20 years old to in their 60s, and patients generally had visual snow for minimum several years, up until about 15 to 20 years. So we'll be looking at that data, but I haven't got the result at this stage.
And then in terms of the migraine controls, did you look at whether they were migraine with aura or without aura?
Again, we have the data at the moment. We've only got 8 subjects, so we've got 9 out of our visual snow group. So we're hoping at some stage to be able to do a sub-analysis as well of looking at patients with visual snow without migraine, patients with visual snow and comorbid migraine, as well as migraine only, and see. But it's a numbers things at this stage. The numbers are too small to make any meaningful conclusions from that.
This is always the question: is any thoughts about how this could lead to treatments in our clinic? No.
I don't know. I mean, at this stage, we do not know for any of these disorders of thalamocortical dysrhythmias, either tinnitus or migraine, in which way that translates to treatment. The treatments for snow tend to be relatively broad, and they tend to overlap a lot with the migraine treatments, but I don't think this is necessarily going to inform our treatment choice further.
There's a question here, can the phase amplitude coupling give some sense of causality regarding which frequency band controls the other?
I don't think so. Generally, we think that it is the alpha currents, so the low-frequency alpha currents that control the gamma circuitry. So the way the brain generally works is that our low-frequency currents synchronize the focal cortical gamma currents, but we don't know if this is different or reversed in this pathological state.